Esophageal tumors. Hazem Hamid, Suchin Wani 48. Esophageal cancer is the 8th most common cancer worldwide, with an estimated 456,000 incident cases, representing 3.2% of all cancer cases diagnosed annually. It is also the 6th leading cause of cancer mortality worldwide, accounting for approximately 400,000 deaths, 5%, of all cancer deaths annually. 1,2 In 2018, it is estimated that there were 17,290 new cases and 15,850 deaths due to esophageal cancer in the USA. 3 The lifetime risk of esophageal cancer in the USA is 1 in 125 men and 1 in 400 women. 4 Esophageal cancer usually presents at an advanced stage, and thus curative treatment is limited and the prognosis is poor, with a mortality to incidence ratio of 0.88. Overall 5-year survival less than 20%. 2,5 Recent data suggest an improvement in 5-year survival rates, especially in patients with early and locally advanced cancers. 4,6 Esophageal cancer has two main subtypes: esophageal squamous cell carcinoma, ESCC, and esophageal adenocarcinoma, EAC. Both subtypes are associated with distinct geographic distributions, time trends, and risk factors. 6,7 Carcinomas. Esophageal squamous cell carcinoma (ESCC) is the most common form of esophageal cancer worldwide, Fig. 48.1. Although it is no longer the most common form of esophageal carcinoma in Western societies, ESCC continues to be the most prevalent type of esophageal cancer in the East, representing 90% of all cancers in most Asian, African, and Eastern European countries. 8 The areas of highest risk for ESCC are in two geographic belts: the Asian esophageal cancer belt across Central Asia from the Caspian Sea to northern China, and a belt on the eastern coast of Africa, from Ethiopia to South Africa. See Fig. 48.1. 9,10 Recent data on the trend of ESCC incidence in the USA between 1999 and 2008 indicate substantial regional variations. The data reviewed covered 85% of the U.S. population and found that the national age standardized incidence rate for ESCC was 4.93 per 100,000 in men and 2.30 per 100,000 in women. The incidence was highest in patients older than age 65. Over the study period, the incidence of ESCC in the USA fell by 3.41% and 3.13% per year in men and women, respectively. The majority, 70.8%, of esophageal cancers diagnosed during the study period were EAC rather than ESCC. 11 Although ESCC is more common in men than women, the ratio varies among low-risk areas like the USA, 4:1, and high-incidence areas of China and Iran where the ratio is lower, approaching or even exceeding 1:1.12. Environmental factors may be important in explaining the geographic variability in the incidence of ESCC. The etiologies and risk factors vary in low and high incidence areas. 13 A population attributable risk of 89% using cigarette smoking, alcoholic beverage consumption, and low consumption of fruits and vegetables was reported in a study in the USA. 14 In contrast, a large cohort study conducted in China found that tobacco smoking played little role in ESCC risk. 15 In industrialized countries, the two most important risk factors are tobacco use and excess alcohol consumption, box 48.1. 16-19 Furthermore, these two independent risk factors have a synergistic effect on cancer incidence. 20 The risk of developing ESCC with active tobacco smoking increases 3 to 9-fold. 21,22 Although the highest risk has been reported with smoking cigarettes, other forms of tobacco use such as pipe, cigar, hookah smoking, chewing tobacco, and the Asian betel quid have also been linked to ESCC. 23 Exposure intensity and longer duration have been reported to be associated with the risk of ESCC. 24. 25 Tobacco-specific nitrosaminas and polycyclic aromatic hydrocarbons are thought to be the major carcinogenic substances in tobacco. Alcohol use has been reported to have a slightly lower risk compared to tobacco, increasing risk of ESCC by 3 to 5-fold. 21 The risk increases significantly with alcohol intake above the maximum recommended U.S. dietary guidelines of 140 g/week. 18 Acetaldehyde, the first metabolite of ethanol metabolism, is a Class I carcinogen. In developing regions, factors such as nutritional deficiencies appear to have a stronger relation to the incidence of ESCC. 19,26 Although the exact mechanism is unclear, low socioeconomic status per SE is a risk factor for ESCC, even after adjusting for tobacco, alcohol, age, and many potential risk factors. 7,27,28 Micronutrient deficiencies, such as vitamin A, C, and E, are also risk factors. 29,30 These vitamins are thought to have important antioxidant properties, preventing formation of free radicals and nitrosamines. However, a 6-year randomized trial conducted in China with 20-year follow-up showed that multivitamin supplementation did not reduce risk in a subpopulation of persons at high risk for ESCC. 31 Other nutritional deficiencies, such as folic acid, zinc, and selenium, have also been reported as risk factors for ESCC. Decreased intake and impaired metabolism of folate, mostly due to gene polymorphisms, have been proposed as risk factors for several GI malignancies, including ESCC. 32 In a case control series, lower serum levels of folic acid were reported of patients with ESCC. 29 The trace elements zinc and selenium are protective against ESCC. 33-35 Zinc deficiency is thought to potentiate the carcinogenic effect of nitrosamines. Selenium supplementation is also thought to have chemopreventive effects against ESCC. After a 10-year follow-up, a study showed that selenium supplements, along with beta-carotene and vitamin E, reduced risk of esophageal cancer death by 17% among participants younger than 55 years old. 33-36 A systematic review of predominantly case control studies demonstrated that higher intake of fruits and vegetables probably decreases the risk of esophageal cancer, with each increment of 50 g/day of raw vegetables and fruit associated with a 31% and 22% decrease in risk of esophageal cancer, respectively. 14 Other dietary factors have also been theorized to increase the risk of ESCC. High-temperature beverage drinking has been associated with increased risk of ESCC in multiple studies, likely due to the chronic thermal injury. 37 Yerba mate, a hot herbal tea commonly consumed in South America, has been found to be a risk factor for ESCC. 38 Other previously reported risk factors, such as ingestion of N-nitroso compounds, animal carcinogens found in cured meat products and pickles, and Fusarium verticilioides, a fungus found on maize, have mixed evidence as risk factors for developing ESCC. 39,40 Multiple studies have shown a possible association of ESCC and infection with HPV. 41 Recently, a large international consortium performed complex serological analysis for multiple HPV serotypes in ESCC cases and control subjects and found a BASR per 100,000 10.5 to 26.55.6 to 10.54.0 to 5.63.1 to 4.02.2 to 3.11.5 to 2.21.2 to 1.50.9 to 1.20.0 to 0.9 No data. ACSCC Fig 48.1 Age standardized incidence rate, ASR, per 100,000 men of esophageal adenocarcinoma, A, and squamous cell carcinoma in men, B. AC, adenocarcinoma, SCC, squamous cell carcinoma. From Rubenstein J.H., Shaheen, New Jersey. Epidemiology, Diagnosis, and Management of Esophageal Adenocarcinoma. Gastroenterology 2015, 149-2, 302-17, E1. 702 Part V Esophagus. Very limited evidence for an association of HPV with ESCC. 42 No definitive association can be proved at this time, and further investigation is necessary. 43 Some esophageal disorders increase the risk of ESCC. As discussed in Chapter 44, it is estimated that the prevalence of ESCC among patients with achalasia is approximately 5%. 44 between years 1 and 24 after diagnosis of achalasia, the risk is increased 16-fold, especially in men. 45 In fact, a large achalasia cohort from Sweden was shown to have an increased risk for both ESCC and EAC. 46 The mechanism is likely due to stasis of food material in the esophagus, leading to chronic inflammation. Similarly, as discussed in Chapter 28, patients with esophageal strictures from lye ingestion have an increased risk of ESCC occurring decades after the initial ingestion. 47 Patients with esophageal webs, such as those with Plummer-Vinson syndrome, iron deficiency anemia, dysphagia, and post-cricoid webs, and with Fanconi anemia, an inherited bone marrow failure linked to several cancers, are also at increased risk for ESCC. See Chapter 43.7, 48. Another rare condition associated with ESCC is tylosis, an autosomal dominant disorder characterized by hyperkeratosis of the pons/solase and leukoplakia. See Chapter 25. The tylosis esophageal cancer gene TOC, RHBDF2, has been localized to chromosome 17q25.49. Recent reports have suggested that this gene may be epigenetically silenced rather than mutated. 50 In one report, the risk of developing ESCC in those with this gene was 95% by the age of 65 years. 51 Certain factors are protective for ESCC. These include obesity and frequent use of aspirin and NSAIDs. 52-55 Esophageal adenocarcinoma EAC is the second most common form of esophageal carcinoma worldwide, see Fig. 48.1. The prevalence and incidence of EAC has not only changed over time, but geographically as well. ESCC used to be the most common type of esophageal cancer in both Western and Eastern countries. Based on surgical series, EAC of the esophagus was uncommon prior to 1978.56 in Western countries. Its incidence has markedly increased such that in 1994, EAC surpassed ESCC in prevalence in the USA. Today, EAC is the predominant type of esophageal cancer in the West. In the USA, its incidence among white men rose from 0.5 to 0.9/100,000 in the 1970s to 3.2 to 4.0/100,000 over the ensuing 2 decades. 57 This shift represents a 463% and 335% increase among white men and white women, respectively. 58 More recent population-based studies carried out from 2003 to 2007 estimated the incidence of EAC to be 5.3/100,000. 59 EAC was 8 times more common in men than women, and 5 times more common in Caucasians than African Americans. Furthermore, this rapid increase in the incidence of EAC is not isolated to the USA. A similar trend has been noted in other Western countries such as the United Kingdom, Iceland, and Australia. 60-64 Furthermore, based on mathematical predictive models, the incidence of EAC is expected to continue to rise till 2030, at which point the predicted incidence of EAC will be 8.4 to 10.1 per 100,000 person-years. 65 The overall 5-year observed survival rates for EAC is strongly dependent on the stage at diagnosis and is among the lowest for all cancers. A recent analysis using the USA National Cancer Institute's Surveillance, Epidemiology, and End Results (SEER) registry showed that the proportion of EAC that had localized, regional, or distant stage disease remained relatively stable, 40% of EAC patients diagnosed with distant stage disease. Recent data also suggest an overall improvement in 5-year survival rates, with the greatest improvement in patients with localized disease reflecting improvements in curative treatment modalities. 4 The relationships between EAC of the distal esophagus and adenocarcinomas of the esophagogastric junction and the gastric cardia are discussed in chapters 47 and 54. This geographic change in EAC incidence over time is thought to be related to the significant increase in GERD, see Chapter 46, and, more importantly, obesity in Western societies. The epidemiologic gradient across both Western and Eastern countries may be related, in part, to socioeconomic status, because high socioeconomic status is more commonly seen in EAC, and low socioeconomic status is more commonly seen in ESCC. 27,58. However, other indicators of improved socioeconomic status including per capita gross domestic product and level of education have not correlated with the observed esophageal cancer gradient in different parts of the world. 58. Because the rise in the incidence of EAC has been so dramatic, the possibilities of misclassification and/or overdiagnosis have been raised. A population-based study using data from SEER 9, which represented approximately 10% of the U.S. population between 1973 and 2001, found that reclassification of EAC to ESCC and adjacent gastric cardia cancer was unlikely to change the incidence of EAC. The anatomic distribution of esophageal cancer has shifted from the upper third of the esophagus to the lower third. The lower third of the esophagus, the location where adenocarcinoma usually arises, was the only esophageal location with an increased incidence. Because there had been minimal change in the rates of in situ or localized disease and the fact that the mortality of EAC had also increased significantly, sevenfold, from 2 to 15 deaths/million, overdiagnosis was unlikely to explain the marked increase in EAC incidence. 66. Furthermore, the possibility of heightened surveillance with EGD as a potential reason for the observed dramatic increase in the incidence of EAC was negated by showing that the rates of EAC increased in white men and women in all stage and age groups. 67. In general, risk factors affecting EAC incidence are commonly seen in economically developed countries. 5. Similar to ESCC, tobacco is a risk factor for EAC, see box 48.1. 13,17,18. Pooled data from the International Barrett and Esophageal Adenocarcinoma Consortium, Beacon, confirmed association between smoking and EAC, or 1.96, 95% CI 1.64 to 2.34. A dose-response relationship was also seen. Heavy smokers had the highest risk of cancer. Furthermore, smoking cessation has been shown to be associated with reduced risk of cancer, smoking cessation greater than or equal to 10 years associated with a 30% lower risk of EAC. 68. In contrast to ESCC, alcohol does not seem to be as strong a risk factor for EAC or Barrett esophagus, B, as it is for ESCC. 69. Pooled analysis of 11 studies from Beacon showed no association between alcohol consumption and risk of EAC. 70. Box 481. Risk factors for ESCC and EAC. ESCC tobacco, alcoholic beverages, low consumption of fruits and vegetables, low socioeconomic status, micronutrient deficiencies, high temperature foods, achalasia, lie ingestion, rare disorders, Plummer-Vinson syndrome, Fanconi anemia, and tylosis, EAC, tobacco, GERD, obesity, EAC, esophageal adenocarcinoma, ESCC, esophageal squamous cell carcinoma. Chapter 48 Esophageal Tumors 703 48 GERD is the most important risk factor for the development of EAC, see chapters 46 and 47. 71 Although most of the large studies are in agreement over the increased risk, the reported risk has varied from 4 to 8-fold. 72-74 A study in Sweden showed that the risk of EAC in individuals with recurrent symptoms of GERD, at least weekly heartburn and/or regurgitation symptoms, was 8-fold higher than individuals with less frequent symptoms, or 7.7, 95% CI. 5.3 to 11.4, 0.72 This study also showed that the risk of EAC was especially high among individuals with more severe and longer-lasting GERD symptoms, or 43.5, 95% CI 18.3 to 103.5. A recent pooled analysis of individual-level data from 5 large population-based case control studies in Beacon reported a strong dose-dependent relationship between frequency of GERD symptoms and EAC, at least weekly, or 4.81, 95% CI 3.4 to 6.8, daily symptoms, or 7.96, 95% CI 4.51 to 14.75 Although GERD is a well-established risk factor for EAC, most patients with GERD never develop EAC. In fact, the majority of patients with EAC deny any substantial prior symptoms of GERD. 76 It is believed that, in predisposed individuals, GERD leads to distal esophageal injury resulting in an aberrant healing process resulting in B. B is the only identifiable premalignant condition for EAC and is defined by the replacement of the normal stratified squamous epithelium with a columnar-lined distal esophagus with intestinal metaplasia. See Chapter 47. B is seen in 7% to 15% of individuals with GERD and is estimated to be present in 1% to 2% of the general adult population. 77 B patients have a 10 to 55-fold higher risk of EAC, however, progression to EAC from B has been reported in a small percentage of patients, 0.12% to 0.3% per year. 77-79 Similarly, obesity is another strong risk factor for EAC, and this risk increases with higher BMI. 80-82 The increased risk of EAC in obesity has been estimated to be 2 to 5-fold. 83 In addition, abdominal obesity, independent of the BMI, has been shown to be associated with an increased risk of EAC. 84-85 A high intake of dietary calories and fat, by itself, is also a risk factor for EAC. 86 Obesity may increase the risk of hiatal hernia and GERD via increased intra-abdominal pressure. 71 However, abdominal obesity is associated with B even after adjusting for GERD, and obesity is associated with EAC even in the absence of GERD symptoms. 83 In addition to its mechanical effect, abdominal obesity is also associated with alterations in circulating levels of peptides that are associated with B and EAC. 10-87 Metabolic syndrome has been associated with B and EAC. 88-89 In addition, studies have also found associations between insulin-like growth factor, leptin, and adiponectin with progression of B to EAC. 10 The striking male predominance in esophageal cancer has raised the question as to whether sex hormones might play a role. When male-to-female ratios of EAC and ESCC, diagnosed between 1992 and 2006, were calculated, the highest male-to-female rate ratio was seen among Hispanics, 20.5, followed by Caucasians, 10.8, and African Americans, 7.0. In contrast, the male-to-female incidence rate ratios in ESCC were much lower. These findings supported the hypothesis that female sex hormone exposure might play a protective role in the development of EAC. 90 The differences in the risk of EAC among men may also be related to differences in use of tobacco or types of obesity. Several factors have been reported to have a protective role against developing EAC. The prevalence of Helicobacter pylori infection, a known risk factor for gastric cancer, has been reported to be inversely associated with EAC. 91-93 This risk reduction has been estimated at 50%. The infection appears to decrease EAC risk by reducing gastric acidity. Also, as with ESCC, aspirin and NSAIDs use appears to be protective in EAC. 94-96 Observational studies have also shown that the use of PPIs reduces the risk of neoplastic progression among B patients by 71% as shown in a systematic review and meta-analysis. 97 Similarly, statins have been shown to reduce the risk of EAC, especially in B patients. 98 Finally, an inverse association between fruit and vegetable consumption and EAC has been shown. 71 Pathogenesis Human cancers occur in a multi-step manner as a result of an accumulation of epigenetic changes and genetic alterations. See Chapter 1. 99-100 A combination of environmental factors, hereditary factors, and acquired genetic alterations are likely to be important risk factors in the development of esophageal cancer. In EAC, there is a gradual accumulation of somatic cell genetic abnormalities that occur during the metaplasia-dysplasia carcinoma sequence in the esophageal epithelium. See Chapters 1 and 47. The inflammatory microenvironment and somatic genomic alterations in stem cell populations are believed to mediate progression from B to EAC. 101 An understanding of the sequence of these abnormalities may lead to a more accurate stratification of patients according to their individual cancer risk. 102 Because there is some evidence to suggest that only patients with a complete pathologic response to neoadjuvant therapy have a survival benefit, discussed later, a search is underway for prognostic and predictive genetic markers that would tailor a more efficacious multimodal therapy. 103-105 ESCC, on the other hand, is thought to arise from hyperproliferative epithelium that progresses to low, intermediate, and high-grade dysplasia, HGD, leading, ultimately, to invasive cancer. 106-107 Both concurrent genetic changes and epigenetic modifications, in the form of hypermethylation of tumor suppressor genes, occur frequently in both EAC and ESSC. 108-110 Although most cases of B and EAC are sporadic without a definite family history, there are several findings that suggest a genetic component. These findings include familial clustering, the fact that only a subset of patients with GERD develop B, and that the amount of reflux is not an accurate predictor of B development. 111-113 In these cases, the risk of developing B is strongly influenced by gene-gene and gene-environment interactions, see Chapter 47. Based on the description of the 6 essential components in human carcinogenesis, 114 molecular factors have been described for each of these 6 steps in esophageal cancer, as summarized below. 115-1. Self-sufficiency in growth signals. Cancer cells can either make their own growth factors, autocrine effect, see Chapter 4, or alter their growth factor receptors and signaling pathways to free themselves from exogenous growth-limiting signals. For example, expression of the gene for EGF receptor 2, HER2/neu, is a prognostic factor in esophageal cancer. 116-118 HER2/neu gene amplification correlates with shortened patient survival and independently predicts poor outcomes in patients with EAC. 119 Conversely, low expression of HER2/neu is associated with an improved response to neoadjuvant chemoradiotherapy than tumors with high HER2/neu expression. 120 Similar effects have been shown for ESCC. 121-122 Furthermore, in ESCC, expression of cyclin D1, a key cell cycle regulator, see Chapter 1, has been associated with shorter patient survival compared to cyclin D1 negative patients. 123-2. Insensitivity to anti-growth signals. Inactivation of tumor suppressor genes is an important mechanism by which tumor cells become desensitized to anti-growth signals. This may happen by mutation, loss of heterozygosity, or promoter hypermethylation. 115 Expression of the tumor suppressor gene TP53 in ESCC is an independent prognostic factor. Tumors with low p53 staining are associated with significantly longer survival than tumors with high p53 protein expression. 124-125 Also, p21 staining in ESCC has been associated with an improved survival. 126-127 In ESCC patients whose tumors had high levels of p16 had longer survival. 128-3. Avoidance of apoptosis. Apoptosis, programmed cell death, puts a brake on expansion of the cell pool. A tumor's capability to expand is determined not only by its rate of cell proliferation but its avoidance of apoptosis. Some important regulators of apoptosis include BAX, BCL2, and BCLX. Expression of these 704 part V esophagus proteins, alone or in combination, correlates with prognosis and response to neoadjuvant chemoradiation. 129-130 Survivin, another member of the inhibitor of apoptosis gene family, has been found to be a useful predictive factor in neoadjuvant therapy for esophageal cancer. Specifically, partial responders to neoadjuvant chemotherapy have lower survivin expression than non-responders. 131 Thus, future therapeutic strategies to reduce survivin expression or block survivin signaling pathways may increase histopathologic response rates and prognosis. 132-4. Uncontrolled replicative potential. Malignant cells, by an overexpression of telomerase, destabilize mechanisms that limit their proliferative capacity and they thus become resistant to cellular aging and death. Although there seems to be an increase in the expression of the human telomerase reverse transcriptase catalytic subunit in the pathogenesis of EAC, there are no studies showing any prognostic significance of the finding. 133-135-5. Sustained angiogenesis. Sustained angiogenesis is crucial for the development, progression, and eventual metastasis of cancer. Angiogenesis factors such as vascular endothelial growth factor, VEGF, COX-2, and fibroblast growth factor receptor 1 have been suggested as potential prognostic factors in esophageal cancer. Of these, VEGF seems to be the most important. 132 High expression of VEGF is an independent, negative prognostic factor in ESCC, although a correlation in EAC has not been demonstrated. 136 COX-2 is known to increase progressively as the tissue progresses through Barrett metaplasia to dysplasia and to frank EAC. 132 In ESCC, COX-2 overexpression correlates with depth of tumor invasion, tumor stage, and reduced survival. 137 Amplification of fibroblast growth factor receptor 1 was shown to be an independent adverse prognostic factor in ESCC. 138 Expression of thymidine phosphorylase, another angiogenic factor, predicts an only partial response to chemoradiation in patients with ESCC. 139 Invasion and metastasis. Abnormalities in cell-to-cell adhesion molecules, i.e., E-cadherent glycoproteins, catenins, and matrix metalloproteins, and their inhibitors are associated with poor histologic differentiation and greater tumor invasion and nodal metastasis. 140-142 Clinical features. Patients with EAC and ESCC have a similar clinical presentation despite the differences in demographics and risk factors. In the early stages, most patients are asymptomatic. However, as the disease progresses, progressive dysphagia and weight loss are the most common symptoms. The diagnosis is often delayed because patients experiencing dysphagia tend to avoid the foods causing the symptom and adjust their dietary intake. Dysphagia is initially with solids but progresses to liquids in the later stages of the disease. Solid food dysphagia typically occurs with an esophageal luminal diameter of 13 mm or less. The severity of dysphagia and concomitant weight loss from decreased oral intake is proportional to the degree of luminal obstruction. The point of difficulty with swallowing as localized by the patient is a poor predictor of the actual location of the mass. Odynophagia is a less common symptom and usually indicates the presence of an ulcerated lesion. Other less common clinical presentations include iron deficiency anemia, palpable cervical lymphadenopathy, and or chest pain. Chest pain, often radiating to the back, suggests the possibility of invasion into periesophageal structures. Tumor erosion can lead to an esophageal respiratory fistula, which can present as refractory cough, recurrent pneumonia, or pleural effusions. A rare complication is esophageal aortic fistula, which can cause massive upper GI hemorrhage and exsanguination. Hoarseness is another rare presentation due to recurrent laryngeal nerve injury from the tumor per SE or associated lymphadenopathy. Metastatic lesions can be found not only in lymph nodes, but also in lungs, liver, brain, and bone. Diagnosis laboratory tests are nonspecific and can reveal an anemia, iron deficiency or chronic disease type, hypoalbuminemia, and or hypercalcemia, usually associated with osteolytic metastasis. Although paraneoplastic syndromes are rare with esophageal cancer, ESCC rarely can cause hypercalcemia due to tumoral production of a circulating parathyroid hormone-related protein. 143 There are no specific serologic markers for esophageal cancer. The diagnosis of esophageal cancer is primarily made by endoscopic biopsies in a patient presenting with progressive dysphagia to solids, Fig. 48.2. The endoscopic appearance is similar between advanced ESCC and EAC, however, approximately 3/4 of all EAC lesions are found in the distal esophagus, whereas ESCC is more frequent in the proximal to middle esophagus. Esophageal cancer can appear as a mass, raised nodule, ulceration, depression, stricture, or subtle irregularity in the mucosa. It is critical for endoscopists to spend adequate time inspecting the esophagus and document landmarks such as the gastroesophageal junction, extent of B using the PROG-C, circumferential, and M, maximal extent, criteria, the presence or absence of extension into the stomach, and the exact location of the tumor. 144 These data points determine the surgical technique used in the management of patients with esophageal cancer. Clear description of morphologic features of tumors may also help in determining candidacy for endoscopic eradication therapies. Therapies that have become standard of care in the management of early esophageal cancer, ESCC and EAC. Various other imaging modalities can aid in diagnosis. Routine chest radiography can reveal nonspecific findings such as aspiration pneumonia, a dilated esophagus with an air fluid level, pseudoachalasia, metastatic lesions in the lung parenchyma, pleural effusions, or signs of fistulas. Barium esophagogram can be helpful in diagnosis of esophageal cancer. A sign of early cancer with this modality is an abnormal esophageal mucosal lining, which can represent a plaque, polypoid lesion, ulceration, or nonspecific focal irregularity. Advanced tumors may be seen as overt masses, strictures with distinct shoulders, or luminal narrowing. Although it generally has fallen out of favor owing to widespread availability of endoscopy, barium esophagogram can be very useful prior to endoscopy in suspected esophageal respiratory Fig 48.2 endoscopic image of a mass in the distal esophagus in the setting of Barrett esophagus, consistent with adenocarcinoma. Chapter 48 Esophageal Tumors 705 48 Fistulas. When used for this concern, the endoscopist can have a roadmap of the anatomy prior to endoscopic stenting. Specific care should be taken to use barium as a contrast agent as opposed to hyperosmolar agents, diatrizoate meglumine and diatrizoate sodium, which carry a risk of severe pulmonary edema and pneumonitis with aspiration. CT may demonstrate esophageal wall thickening/irregularity, focal esophageal stricture with proximal dilation, or an intraluminal mass may be seen. Signs of aspiration pneumonia, metastatic lesions, lymphadenopathy, and esophageal respiratory fistula may be seen. As stated, endoscopy with biopsy has the highest yield for diagnosis of esophageal cancer and is the standard for diagnosis, Figs 48.3 and 48.4. Several imaging modalities have been used in the context of three major clinical applications: a. Improved detection and identification of patients with early cancer during screening and surveillance endoscopy, b. Prediction of histology and real-time diagnosis during endoscopy, and c. Guiding endoscopic eradication therapies. Technologic advancements have allowed the creation of smaller charge couple device chips that are capable of producing images with high resolution, over 850,000 to 2.1 million pixels, displayed on monitors with a 16:9 aspect ratio, resulting in superior imaging quality compared to standard definition white light endoscopy, WLE. High-resolution magnification endoscopes can optically magnify images up to 150 times, although not routinely available in the USA. High-resolution endoscopy, with or without magnification endoscopes, has been shown in several studies to increase the yield for detection of dysplasia and early cancer. 145-149 White light endoscopy overall has a low sensitivity rate of 55% to 63% in the detection of early ESCC. 150 The use of high-resolution WLE, where available, should be the minimum standard for evaluation of B patients undergoing surveillance or being considered for endoscopic eradication therapy, EET, and for other subtle lesions in the esophagus, esophageal squamous dysplasia and early ESCC, a practice endorsed by GI Society Guidelines. 151-152 Endoscopic findings can vary from relatively normal appearing mucosa, submucosal infiltrative pattern, to ulcers, nodules, and overt masses. Several other endoscopic techniques can also help identify areas of dysplasia and malignancy, including narrowband imaging, chromoendoscopy, conventional or electronic, autofluorescence imaging, AFI, and confocal laser endomicroscopy, CLE. The chapter on Barrett esophagus discusses these imaging modalities in further detail, see Chapter 47. Conventional chromoendoscopy involves the use of special stains to highlight subtle architectural changes to help direct biopsies and predict histology. Lugol's iodine, methylene blue, acetic acid, crystal violet, and indigo carmine are the most commonly used stains. 153-154 Lugol's iodine solution consists of a 0.5% to 3.0% aqueous solution of potassium iodide. Iodine stains glycogen-containing cells of the normal esophageal epithelium and is not taken up by dysplastic or malignant cells that are glycogen-depleted, pink color sign. Chromoendoscopy with Lugol's iodine staining has become the standard of care for screening of ESCC in high-risk populations and has been shown to have a high sensitivity rate of 89% to 100% with highly variable specificity rates due to false positive lesions. 150,155 In contrast, methylene blue, acetic acid, and indigo carmine staining are more useful in the detection of glandular abnormalities, as seen in EAC. These stains are sprayed in the esophagus with the intent of improving characterization of the mucosa, resulting in selective uptake, vital staining methylene blue, or enhancement of mucosal surface pattern, contrast staining indigo carmine, acetic acid. Of importance, there are many limitations of conventional chromoendoscopy including, a. Dysplasia and inflammation, esophagitis, are not distinguishable from each other, b. These techniques are generally cumbersome, time-consuming, and require dye spraying equipment, c. Difficulty in achieving complete and uniform coating of the mucosal surface with the dye, d. Inability to detect vascular patterns, e. Conflicting published data, f. The need for magnification endoscopy, and g. Lack of standardized classification. Conventional chromoendoscopy has largely been replaced by optical chromoendoscopy, see below, while evaluating patients with Barrett esophagus and EAC. Optical chromoendoscopy is another modality to detect signs of dysplasia and cancer by using selective light filters to highlight subtle architectural and vascular changes in the mucosa. This method avoids some of the concerns associated with conventional chromoendoscopy highlighted above. Several variations of electronic chromoendoscopy are available by different manufacturers, but most of the published studies have described the use of narrowband imaging, NBI, Olympus, Tokyo, Japan, in the setting of B. NBI is an imaging technique that is based on the optical phenomenon that the depth of light penetration into Fig. 48.3 histopathology of esophageal adenocarcinoma specimen showing irregular, malignant glands with luminal mucin production involving esophageal mucosa, with inflammatory stromal response. A component of signet ring cells with large cytoplasmic vacuoles and eccentric nuclei is seen at the left center of the image. 200 times. Courtesy Dr. Michael Argiers, Denver, Colorado. Fig. 48.4 histopathology of esophageal squamous cell carcinoma showing nests of malignant keratinocytes with glassy cytoplasm, nucleoli, and keratin involving esophageal mucosa, with an inflammatory stromal response. A keratin pearl is seen at center of the image. 100 times. Courtesy Dr. Michael Argiers, Denver, Colorado. 706 Part V. Esophagus tissue depends on the wavelength. The shorter the wavelength, the more superficial the penetration. Use of blue light with narrow band filters enables detailed imaging of the mucosal and vascular surface patterns with a high level of resolution and contrast without the need for dye chromoendoscopy. 156 NBI is the most widely studied electronic chromoendoscopy technique to predict histology during surveillance, improve detection of dysplasia, and guide endoscopic eradication therapies. An international working group of experts recently established a classification system for B using NBI. 157 A systematic review and meta-analysis showed that advanced imaging techniques, conventional and optical chromoendoscopy, increased dysplasia or cancer detection by 34%, 95% CI 20% to 56%. 158 NBI without magnification has been evaluated in the detection of ESCC and squamous dysplasia. Endoscopically suspicious lesions for early ESCC appear as well-demarcated brown areas at NBI without magnification, Fig. 48.5. A prospective comparative study showed that NBI examination was reliable for the detection of early ESCC with sensitivity of 88% and specificity of 75%. 150,159 AFI involves a technique that uses short wavelength blue or ultraviolet light to stimulate biological fluorophores, e.g., collagen, porphyrins, flavins, aromatic amino acids, in the esophagus. This technology has been mostly used in clinical trials for detecting B-associated neoplasia. Pooled analysis from 5 prospective trials showed that AFI had little effect on the diagnosis of neoplasia, with additional diagnostic value of 2% compared to WLE, and with a high false positive rate, 78%, 0.160. Given this limited additional diagnostic and therapeutic value, AFI is not widely used clinically. CLI allows real-time, in vivo microscopic imaging of the esophageal mucosa. It involves administration of a fluorescent dye, most commonly fluorescein sodium, that is taken up by normal mucosal cells. Fluorescent dye uptake is not seen in dysplastic cells, and thus they appear dark. This method creates magnification up to 1000 times. The only commercially available method currently for CLI is a probe-based instrument that can be passed through an accessory channel on the standard upper endoscope. Several prospective randomized controlled studies have reported that adding CLI to high-definition WLE significantly improves the diagnostic yield for B-associated neoplasia. 161,162 Optical coherence tomography emits near-infrared light to provide cross-sectional images of tissue, which also has the potential advantage of identifying submucosal lesions. Initial studies showed encouraging results for detecting dysplasia, but limitation for its use included small field of view and slow imaging processing. 163 ABCD Fig 48.5a, high-definition white light endoscopic image of esophageal squamous cell carcinoma showing subtle irregularities in the esophagus. B. Narrow band imaging of the same area showing well-demarcated dark brown area. C. Magnification NBI image showing abnormal intraepithelial capillary loops pattern. D. Lugel's chromoendoscopy with circumferential unstained lesion. Chapter 48 Esophageal Tumors 707-48 Volumetric laser endomicroscopy, VLE, is a second-generation optical coherence tomography technique that produces real-time cross-sectional images of large areas in the esophagus. Envision VLE, NVLE, 9 Point Medical Incorporated, Bedford, MA, USA, is approved by the Food and Drug Administration and is currently commercially available. This device has the ability of laser marking of suspicious areas for subsequent treatment. Using a diagnostic algorithm in a prospective cohort, VLE was shown to have a sensitivity of 86%, 95% CI 69 to 96, specificity of 88%, 95% CI 60 to 99, and diagnostic accuracy of 87%, 95% CI 86 to 88, to detect B-associated dysplasia. 164 This new technology is still not widely available. Screening and surveillance EAC Screening and surveillance are covered under Barrett esophagus, see Chapter 47. The histologic precursors of ESCC include dysplasia and carcinoma in situ, Fig 48.6. 165 Given the time needed for dysplasia to develop into malignancy, screening and surveillance programs are designed to detect these early histologic precursors in an effort to improve survival. Early-stage carcinoma is associated with a substantially improved survival, up to 86% at 5 years, when treated surgically. 166 The primary screening strategy in areas of high ESCC incidence involve Lugel's chromoendoscopy, with endoscopic biopsies obtained from the unstained areas. Vital staining with Lugel's is based on the reversible chemical reaction between the iodine and glycogen present in normal epithelial cells. Dysplastic, cancerous, and inflammatory cells are usually devoid of stain, because of less abundant glycogen, and targeted biopsies can be obtained to confirm dysplasia/malignancy. 167 As mentioned above, Lugel's chromoendoscopy has a sensitivity and specificity of 90%. 155 Some studies showed low specificity of Lugel's solution to detect early ESCC that is likely secondary to difficulty differentiating between dysplasia/neoplasia and inflammation, but targeted biopsies should be helpful. In this situation. 168 Vital staining with Lugel's solution, although simple and inexpensive, is associated with some limitations, including possible iodine allergy, risk of aspiration, or chest pain due to esophageal spasm. NBI allows for clearer depiction of capillary networks and superficial mucosal patterns. Detailed classifications of these abnormalities have been proposed and validated in the identification and staging of squamous dysplasia and early ESCC, see Fig 48.5.169. A recent meta-analysis of 18 studies that included greater than 1,900 patients showed that NBI had a significantly improved specificity compared with chromoendoscopy with no difference in sensitivity. 168 cost-benefit studies have been carried out to assess esophageal cancer screening strategies. 171 study found that a strategy of one-time screening at age 50 would be the best approach in underdeveloped high-risk areas, whereas a 3-time screening strategy starting at age 40, 10-year intervals, would be preferable in areas with better healthcare resources. 171 A community assignment study in China with 10 years of follow-up showed a 1/3 reduction in the cumulative ESC-related mortality in communities where 40 to 69-year-old adults were screened once by Lugol's chromoendoscopy compared with communities without screening. 172 Routine screening for ESCC is also recommended in patients with head and neck cancer. A retrospective study from Taiwan found a higher prevalence of secondary ESCC in head and neck cancer patients receiving routine endoscopies compared with the non-screening group, 4.5% versus 3%, p equals 0.04, with earlier stage at diagnosis, p equals 0.03. 173 The current screening guidelines include 9.1 one-time Lugol's chromoendoscopy for high-risk Asian and African populations beginning at the age of 40. 2 endoscopy with Lugol's or NBI every 6 months to 1 year after completion of therapy for head and neck squamous cell cancer, for 10 years. 3 Screening could also be considered for patients at high risk, tylosis, achalasia, and caustic injury. Other endoscopic techniques covered earlier, such as NBI and AFI, have also been evaluated as screening tools. NBI has been shown in multiple studies to detect early esophageal lesions based on superficial vasculature and surface pattern with excellent sensitivity and specificity, but is still used in conjunction with Lugol's chromoendoscopy. 168 AFI is not sufficiently sensitive for lesions smaller than 10 mm, rendering it a less useful test for screening. 174 Unstated transnasal endoscopy, TNE, using an ultrathin endoscope has been shown to be safe and well tolerated. 175 A study of high-risk patients showed that TNE, with or without optical chromoendoscopy, has excellent specificity and sensitivity for early ESCC. 176 TNE is still not widely available but could be an important tool for ESCC screening. Additional endoscopic techniques include endocytoscopy and high-resolution microendoscopy, which allow for real-time AB. Fig 48.6a, subtle, well-demarcated nodularity in the upper esophagus at the 6 o'clock position concerning for early neoplasia. B. Biopsies confirmed squamous high-grade dysplasia. Courtesy Dr. Jeffrey Kaplan, Denver, Colorado. 708 Part V Esophagus pathological examination of the tissue. Limited initial data are promising, but these techniques are not widely available. 177,178 Non-endoscopic methods for screening such as the use of peroral balloons and sponges have the advantage of being low cost and less invasive compared to endoscopy. However, these techniques have been shown to be inadequate owing to the poor sensitivities for dysplasia and even invasive carcinoma. 179 Combining non-endoscopic cytologic samples with biomarker, such as P53, may improve the sensitivity of the test. 180 Other non-invasive screening methods under investigation include breath markers, volatile organic compounds, antibodies to tumor-associated antigens, circulating microRNAs, and methylated DNA markers. Staging of esophageal cancer is carried out using the American Joint Committee on Cancer Staging System, Fig 48.7, which was last updated in 2017, 8th edition. 181 This system not only separates staging for EAC and ESSC but also presents 3 classification systems separately for EAC and ESCC, the classic reference pathologic, PTNM, stage groups, Fig 48.8, the newly introduced post-neoadjuvant pathologic, YPTNM, stage groups, Fig 48.9, and clinical, CTNM, stage groups, Fig 48.10. This staging system recently revised the definition of the esophagogastric junction such that cancers involving it with epicenters no more than 2 cm into the gastric cardia are staged as EAC, and those with greater than 2 cm involvement of the gastric cardia are staged as gastric cancers. The depth of tumor invasion, T stage, is an important factor because the rich lymphatic supply of the esophagus can provide a route of metastasis. Superficial cancers are defined as either carcinoma in situ, TIS, or T1 tumors. T1 is divided into T1A and T1B depending on whether the submucosa is spared or involved, respectively. Further classification for T1A includes M1, intraepithelial cancer, M2, invasion into the lamina propria, and M3, invasion to the muscularis mucosa. T1B lesions also can be subdivided into SM1, invasion into the upper third of the submucosa, SM2, invasion into the middle third, and SM3, invasion into the lower third. TIS and T1A lesions have a predicted lymph node metastasis rate up to 8% compared to T1B lesions, which have up to a 56% lymph node metastasis rate. 182-184. In addition to the mediastinal nodes, lymph node metastases can occur in the neck and upper abdomen. 185. The risk of lymph node involvement is related to several factors, in decreasing order of frequency: grade 3 histology, SM3 invasion, lymphatic invasion, vascular invasion, SM2 invasion, and SM1 invasion. In ESCC, the best predictors of lymph node invasion are SM3 invasion and vascular invasion, whereas in EAC, the most important predictor is lymphatic invasion. 186. Figure 48.11 shows correlation of survival and the T stage. Staging can be performed by several methods: endoscopy with mucosal biopsies, endoscopic resection, multi-detector CT, MDCT, with 18F-fluoro-2-deoxy-D-glucose PET, 18F PET, and EUS with FNA for cytology. 187,188 Pluritis, HGD, T1A, T1B, T2, T3, T4A, T4B. Epithelium basement membrane lamina propria muscularis mucosae submucosa muscularis propria adventitia aorta M1 N0 N11 or 2 N2 3 to 6 N3 7 or more. CCF Copyright 2016 Fig 48.7 American Joint Committee on Cancer, AJCC. TNM staging classification for carcinoma of the esophagus and esophagogastric junction. T is categorized as either TIS, high-grade dysplasia, T1 cancer that invades the lamina propria, muscularis mucosae, or submucosa and is subcategorized into T1A, cancer that invades the lamina propria or muscularis mucosae, and T1B, cancer that invades the submucosa, T2 cancer that invades the muscularis propria, T3 cancer that invades the adventitia, T4 cancer that invades the local structures, and is subcategorized as T4A, cancer that invades adjacent structures such as the pleura, pericardium, azygous vein, diaphragm, or peritoneum, and T4B, cancer that invades the major adjacent structures, such as the aorta, vertebral body, or trachea. N is categorized as N0, no regional lymph node metastasis, N1, regional lymph node metastases involving 1 or 2 nodes, N2, regional lymph node metastases involving 3 to 6 nodes, and N3, regional lymph node metastases involving 7 or more nodes. M is categorized as M0, no distant metastasis, and M1, distant metastasis. From Rice T.W., Ishwaran H., Ferguson M.K., Blackstone et. Goldstraw P. Cancer of the Esophagus and Esophagogastric Junction, an 8th edition staging primer. J. Thorakonkel 2017, 1236-42. Chapter 48 Esophageal Tumors 709 48 Endoscopy with mucosal biopsies. The role of endoscopy with mucosal biopsies in staging is to characterize the intraluminal mucosal extent of the tumor, location, and to determine the histologic type, ESCC or EAC, and the histologic grade, degree of differentiation. 189 The sensitivity for mucosal biopsies reaches 96% when multiple biopsies are taken, typically 6 to 8. 190 As discussed earlier, NBI and other advanced imaging techniques can be used to Obtain a more accurate assessment of tumor extent. Multi-detector CT and 18-FFDG PET MDCT and 18-FFDG PET scans are commonly used in the staging of esophageal cancer, Fig 48.12. Both ESCC and EAC have high affinity for 18-FFDG, which makes PET scan very helpful in esophageal cancer evaluation. The sensitivity and specificity for 18-FFDG PET in detecting distant metastases in esophageal cancer are 71%, 95% CI 62 to 79, and 93%, 95% CI 89 to 97, respectively, whereas for CT they are 52%, 95% CI 33 to 72, and 91%, 95% CI 86 to 96, respectively. 191,192 studies have shown that CT PET can identify 5% to 28% with metastatic disease, especially at sites not detected on CT alone. In addition, rest aging after neoadjuvant therapy seems to be better accomplished with FDG PET/CT than EUSFNA or MDCT alone. 193 EUS is increasingly used to assess the depth of tumor invasion and to distinguish T1 lesions from deeper infiltration. This distinction helps to choose candidates for stage-appropriate therapies. EUS is the only imaging modality that can clearly delineate the different esophageal wall layers. It is considered by most experts to be the best staging modality for T-stage and locoregional lymph node (N) staging. Video 48.1. In a meta-analysis, the pooled sensitivity of EUS for T stages was 80% to 90% with more than 90% specificity. The accuracy was higher for more advanced T stages. The pooled sensitivity of EUS for N stage was 85%, 95% CI, 82% to 86%. The addition of fine needle aspiration, FNA, of equivocal lymph nodes increased the sensitivity of nodal staging to 97%, 95% CI, 92% to 99%. 194 Endosonographic features of malignant lymph nodes include lesions that are hypoechoic with a rounded and smooth surface, lesions greater than 10 mm, and lesions located in close proximity to the tumor. 195 The role of EUS in the initial staging of esophageal cancer has been questioned, particularly in superficial tumors. 196,197 A recent review in meta-analysis found that EUS has good accuracy in staging superficial esophageal cancers overall. 198 Factors such as location, histologic type of lesion, EUS method used, and the experience of the endosonographer may affect the diagnostic accuracy. Recent data from a systematic review and meta-analysis that assessed the false positive rate of advanced disease on EUS exam at the tumor level, differentiating between T1A and T1B disease, showed that the use of EUS in patients with B with dysplasia and early cancer resulted in a high proportion of patients being falsely overstaged and understaged. 199 Hence, advanced techniques such as endoscopic mucosal resection, EMR, and endoscopic submucosal dissection, ESD, play a pivotal role in determining the true extent of invasion. When compared to CT, EUS has better sensitivity and specificity for locoregional metastasis. 195,200 A meta-analysis G1IA3A EVA IVB IIB0 IB IB3A EVA IVB IIB IC IC IC3B EVA IVB3A IIA IIB3B EVA IVB3B EVA 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 IVB EVA 3B EVA EVA IVB3B G2 G3 G1 G2 G3 G1 G2 G3 N0 TIS PTNM adenocarcinoma PTNM squamous cell carcinoma T1A T1B T2 T3 T4A T4B AB N1 N2 N3 M1 N0 TIS T1B T4A T4B T1A T2 T3 LU/M N1 N2 N3 M1 0 IA IA IIB3A EVA IVB IB IB IB3A 3B EVA IVB IB IIA 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 3B 3B EVA IVB IIA IIA IIB IIB3A EVA IVB IB 3B EVA EVA IVB 3B EVA 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 IVB EVA G1 G2-3 G1 G2-3 G1 G2-3 Fig 48.8 Pathologic stage groups, PTNM, for esophageal adenocarcinoma, A, and squamous cell carcinoma, B. Redrawn from Rice T.W., Ishwaran H., Ferguson M.K., Blackstone et. Goldstraw P. Cancer of the Esophagus and Esophagogastric Junction, an 8th edition staging primer. J. Thoraconcal 2017, 12-136-42. I3A3B EVA IVB I3A3B EVA IVB I3A3B EVA IVB I3A3B EVA IVB 23B3B EVA IVB 3B EVA 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 IVB EVA 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 IVB N0 N1 N2 YPTNM N3 M1 T0 TIS T1 T2 T3 T4A T4B Fig 48.9 Post-neoadjuvant pathologic stage groups, YPTNM, for esophageal adenocarcinoma and squamous cell carcinoma. Redrawn from Rice T.W., Ishwaran H., Ferguson M.K., Blackstone et. Goldstraw P. Cancer of the Esophagus and Esophagogastric Junction, an 8th edition staging primer. J. Thoraconcal 2017, 12-136-42. 710 Part V Esophagus IIIA EVA EVA IVB IIB 3 EVA EVA IVB 3 3 EVA EVA IVB 3 3 EVA EVA IVB EVA 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 IVB TIS 00 N0 CTNM Adenocarcinoma CTNM Squamous Cell Carcinoma N1 N2 N3 M1 N0 N1 N2 N3 M1 T1 T2 T3 T4A T4B TIS T1 T2 T3 T4A T4B ABII 3 EVA IVB 223 EVA IVB 223 EVA IVB EVA 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 IVB EVA 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 IVB Fig 48.10 Clinical Stage Groups, CTNM, for esophageal adenocarcinoma, A, and squamous cell carcinoma, B. Redrawn from Rice T.W., Ishwaran H., Ferguson M.K., Blackstone et. Goldstraw P. Cancer of the Esophagus and Esophagogastric Junction, an 8th edition staging primer. J. Thoraconcal 2017, 12-136-42. Fig 48.11 Survival stratified by PT category. Kaplan-Meier estimates accompanied by vertical bars representing 68% confidence limits, equivalent to plus or minus 1 standard error. A. Esophageal squamous cell carcinoma. B. Esophageal adenocarcinoma. Data from Rice T.W., Chen L.Q., Hofstetter W.L., ETAL Worldwide Esophageal Cancer Collaboration, Pathologic Staging Data. Dis Esophagus 2016, 2977-2433. 00A2 4 years 68 PT4A PT3 PT2 PT1 Ts 10 10 20 30 40 50 60 Survival, %. 70 80 90 100 B PT4A PT3 PT2 PT1 Ts 00 4 years 6 8 10 10 20 30 40 50 60 Survival, %. 70 80 90 100 Chapter 48 Esophageal Tumors 711 48 Comparing EUS, CT, and FDG PET showed pooled sensitivities for detecting regional lymph node metastasis of 80%, 50%, and 57% for the three modalities, respectively. 191 A recent case-only study of esophageal cancer using the SEER Medicare-linked database also showed an improved survival in a cohort of esophageal cancer patients undergoing EUS staging compared to the no EUS or CT PET group, with the exception of stage 0 disease. Receipt of EUS increased the likelihood of receiving endoscopic therapies, esophagectomy, and chemoradiation. Multivariable Cox proportional hazards models showed that a receipt of EUS was a significant predictor for improved survival at 1-year hazard ratio, HR, 0.49, 95% CI 0.39 to 0.59, 3 years, HR 0.57, 95% CI 0.48 to 0.66, and 5 years, HR 0.59. 95% CI 0.5 to 0.68, survival. This improvement in survival is most likely related to accurate staging of patients with esophageal cancer, resulting in appropriate stage-specific therapies. 201 Advanced techniques. Other staging modalities that are performed in selected centers are EMR, ESD, and minimally invasive staging using laparoscopy. 202 The choice and sequence are dependent on the institutional expertise and preference. Conflicting reports on the accuracy of EUS in superficial tumors have led some to believe that EMR and ESD may be more accurate methods for diagnosis and staging. 196,197,203 Both methods not only provide tissue for assessing the tumor's depth of invasion, T stage, and possibly tumor-free margins, but also provide information on grade of differentiation and lymphovascular invasion. EMR and ESD are discussed in more detail later. Staging laparoscopy is considered optional for tumors in the distal esophagus and at the esophagogastric junction, as it may detect otherwise radiologically occult metastasis. 204,205 Treatment. A multidisciplinary approach to the treatment of esophageal cancer is essential and requires input from experts in surgical oncology, radiation oncology, medical oncology, gastroenterology, radiology, pathology, and often palliative care. 206 Tumor location, staging, histologic type, medical comorbidities, and patient preference are factors that must be considered for selecting the proper treatment. Some general principles can be summarized as follows. 207. Surgery is the standard treatment for a medically optimized surgical candidate with a localized, non-superficial tumor. For a patient with a localized tumor who is not a surgical candidate, definitive chemoradiation with curative intent may be considered. For all others, metastatic disease, palliation is recommended. With a wide spectrum of treatment options for esophageal cancer, accurate staging is essential to selecting the appropriate treatment modality. 208 The primary objective is to identify those patients who may benefit from neoadjuvant therapy and those with widespread metastatic disease who are better candidates for palliation. Patient selection is another very important component of the management of esophageal cancer. The evaluation should include medical comorbidities and the patient's current performance status, nutrition, and cardiopulmonary function. Pulmonary complications, pneumonia in particular, are important determinants of early postoperative outcome and are associated with more than fourfold increase in mortality. 209-211 Interestingly, preoperative chemoradiation has been found to be a risk factor for postoperative pneumonia. 211 A scoring system involving spirometry results, age, and performance status is available to predict cardiopulmonary complications. 210 Selection based on mathematical scores may not be superior to a physician's clinical assessment. The two methods are ABC Fig 48.12a, CT scan with distal esophageal thickening, arrow, at site of an esophageal cancer. B and C, FDG PET images showing corresponding intense hypermetabolism in the distal esophagus, B, and in a left paraesophageal lymph node, C, arrow. 712 Part V Esophagus complementary. 212 Importantly, the scores obtained may not be applicable to all institutions or populations. For example, patients with ESCC from Asia have a different risk profile, e.g., pulmonary and hepatic comorbidities from smoking and alcohol use, compared with patients in Western societies with EAC, e.g., cardiac risk factors or comorbidities. 213 Patients with cervical or cervicothoracic esophageal tumors, 5 cm from the cricopharyngeus, are usually poor candidates for surgery because of limitations in surgical techniques. 214 These patients are typically treated with definitive chemoradiation, with an encouraging response rate in a recent study. 215 Surgery resection of the esophagus with en-bloc lymphadenectomy is the cornerstone of curative therapy for patients with locally advanced esophageal cancer. 216 In addition, according to the National Comprehensive Cancer Network, NCCN, guidelines, surgery alone is considered the standard of care and treatment of choice for T1b and T2 cancers without nodal involvement or distant metastasis. Surgery in conjunction with a multimodal approach is indicated for T1 to T4A tumors with lymph node metastases. 204 The final outcomes for patients undergoing esophagectomy are dependent not only on the patient's stage, comorbidities, and performance status, but also on surgical team expertise and center volume. Esophagectomy has the potential for high perioperative morbidity, 40% to 50%, and mortality, 3% to 13%, 217-221. One recurrent theme in the surgical literature is that center volume of esophagectomy is a critical determinant of outcomes. 216, 220, 222. 30-day mortality is inversely related to the number of esophagectomies performed at the center. Treatment in high-volume centers with experienced surgeons along with the availability of ICU management and early detection of complications play significant roles in differential outcomes. The mortality may increase to 20% in low-volume centers, 5 esophagectomies per year. 223-225. The operative mortality in high-volume centers, greater than 20 per year, is estimated to be less than 2%. 226-228. In a review of quality of care indicators, patient selection and multidisciplinary team management were the most important factors influencing outcome in esophageal cancer surgery. 229 techniques. Several different variations on surgical technique have been described for esophagectomy in patients with esophageal cancer. The technique used can be influenced by surgical access site, transthoracic versus transhiatal, extent of lymphadenopathy, type of anastomosis desired, type and method of preparation of the esophageal conduit, pyloric drainage procedure, and route of reconstruction. Most controversies are based on the type of surgical access and the extent of lymph node dissection. 230. The type of surgical access may not only influence the perioperative morbidity and mortality but also the ability to perform extensive lymph node dissection. 212. Transthoracic approaches include Ivor-Lewis esophagogastrectomy, right thoracotomy and laparotomy, and McKeown esophagogastrectomy, thoracotomy, laparotomy, and cervical anastomosis. Transhiatal approaches include laparotomy and cervical anastomosis. 231-236. The reported advantage of the transthoracic approach is better visualization of the mediastinum, which leads to decreased risk of adjacent organ injury, more complete cancer resection and lymph node retrieval, and more accurate staging. 234. Conversely, those in favor of a transhiatal approach note that cure of esophageal cancer is a rare phenomenon achieved in only very early tumors, making esophagectomy usually a palliative procedure. In this regard, a transhiatal approach has a shorter operative time with lower postoperative morbidity. 232. A large population-based study comparing transthoracic and transhiatal approaches found that the transhiatal esophagogastrectomy was associated with lower operative mortality rate, 6.7% versus 13.1%, p equals 0.009. But the long-term survival was not different between the two approaches. 221. Minimally invasive esophagectomy, MI, which includes minimally invasive Ivor-Lewis esophagogastrectomy, laparoscopy and limited thoracotomy or thoracoscopy, and minimally invasive McKeown esophagogastrectomy, thoracoscopy, limited laparotomy or laparoscopy, and cervical incision, has been gaining popularity recently. 237. It is aimed at minimizing surgical trauma and perioperative morbidity and mortality. The technique requires special training and expertise. 238. Minimally invasive surgery has been shown to have similar oncologic outcomes compared to conventional approach. 239. The advantages of minimally invasive surgery include less postoperative pain, a decreased length of hospital stay, lower need for intraoperative blood transfusion, and overall lower cost. 240-242. A recent prospective multi-center trial showed that MI is safe and feasible with low perioperative morbidity and mortality. 2.1%. 243. Despite encouraging results with MI, recent population-based studies failed to demonstrate superiority of MI over conventional approach. 244. Lymph node dissection. Lymph node status is an independent predictor of survival in esophageal cancer. 245. For this reason, aggressive lymphadenectomy is thought to be essential to reduce locoregional recurrence, improve survival, and obtain a more accurate pathologic staging. 246-247. The number of lymph nodes removed during esophagectomy has been shown to be an independent predictor of survival. 248. In patients undergoing esophagectomy without neoadjuvant chemoradiation, the NCCN guidelines recommend that 15 or more lymph nodes be removed for adequate staging. 204. However, in patients who undergo neoadjuvant chemoradiation, the number of lymph nodes does not seem to correlate with increased survival. 249 Outcomes measurement of short-term clinical outcomes after esophagectomy for esophageal cancer is difficult to compare. Among published reports, because of the lack of standard methodology and other inconsistencies. 250 Moreover, outcomes after esophagectomy included in the largest thoracic surgical database in the USA are far better than the ones reported by other national clinical and administrative databases. 251 The most commonly reported complications are anastomotic leak and postoperative pneumonia. A recent updated population-based study on esophageal cancer survival after surgery without neoadjuvant therapy has shown that the long-term survival has not improved since 2000. Rather, it has remained at 30.5% after 5 years. This survival rate in operated patients remained unchanged despite a decrease in the 30-day postoperative mortality from nearly 5% to 2%. 252 The improved postoperative mortality probably reflects better ICU management of complications. 252,253 Thus, improvements in surgical techniques have not translated into better long-term survival outcomes. A substantial fraction of patients with potentially resectable tumors have a pathologic complete response after neoadjuvant chemoradiation, 23% in EAC and 49% in ESCC. 254 Moreover, a recent study that compared surgery to definitive chemoradiation in patients with resectable ESCC showed that the 5-year overall survival was not different for patients with stage I, 80% versus 75.8%, and stage II disease, 78.2% versus 74.6%. 255 Another study showed similar outcomes between surgery and chemoradiation for stage I disease, but the risk of local recurrence, including metachronous lesions, was significantly higher in the chemoradiation group. Most recurrences in the chemoradiation group were intramucosal carcinoma and were cured after salvage therapy, mainly endoscopic. As discussed below. 256 Studies are currently underway to identify patients who can potentially avoid surgery. Chapter 48 Esophageal Tumors 713 48 Endoscopic treatment. EET has revolutionized the management of beer-related dysplasia and early EAC, see Chapter 47, and esophageal squamous dysplasia and early ESCC. The role of endoscopic treatment of esophageal cancer can be either for curative intent or palliation. The former is reserved to mucosal tumors, T1A, confined to the mucosa, M1 or intraepithelial, the lamina propria, M2, or the muscularis mucosae, M3. These tumors have an extremely low chance of harboring lymph node metastasis. Submucosal tumors, T1B, are further classified into SM1, superficial submucosal invasion, SM2, invasion to center of submucosa, or SM3, invasion into the deep submucosa. In contrast to T1A tumors, T1B tumors involving the submucosa have a higher risk of lymph node metastasis, up to 56% in SM3 tumors. 183,184 Endoscopic therapy with curative intent. Endoscopic resection techniques and endoscopic ablation therapy have been used for treatment of superficial esophageal carcinoma. Endoscopic resection has the added advantage of procuring large tissue specimens for pathologic diagnosis and accurate cancer staging. Fig 48.13, 257,258 Both EMR and ESD allow targeted removal of tissue, such as nodular or flat Barrett epithelium with HGD, and T1A cancers. Fig 48.14. The effectiveness and safety of EET in eradicating Barrett-related neoplasia, maintaining remission, and preventing progression to invasive EAC, primary goal of EET, have been demonstrated in multiple studies. 259,260 The basic principles of EET with regard to management of Barrett-related dysplasia and early EAC are as follows. A. Resection of all visible lesions, these are lesions that harbor the highest grade of neoplasia. B. Eradication of the remaining B to reduce the risk of metachronous neoplasia. C. Management of immediate adverse events such as bleeding, perforation, and long-term adverse events such as strictures and recurrence. And D. Enrollment in surveillance programs after achieving complete eradication. 261 EET has now replaced esophagectomy as the standard of care for patients with Barrett-related HGD and early, mucosal, EAC. 262 Although there are no randomized controlled trials comparing esophagectomy with EET, results from population-based and observational studies have reported comparable outcomes, 2 and 5-year EAC survival rates, after EET and esophagectomy, providing confidence in the contemporary management of beer-related neoplasia patients with EET. The most recent ASGE guideline document on the role of EET recommends against surgery and favors EET in B patients with HGD and intramucosal cancer. 259 The role of EMR as a staging and therapeutic tool in the management of beer-related neoplasia is well described. The staging superiority of EMR compared with biopsy specimens is related to a larger and deeper tissue specimen with limited distortion, providing the ultimate proof of invasion depth along with improved inter-observer agreement among pathology using EMR specimens. 258,263 A study that followed 1,000 patients with T1A esophageal carcinoma for around 5 years showed that EMR was very effective, with 94% complete remission rate. 264 A SEER database analysis of 1,458 patients between 1998 and 2008. With T1N0 esophageal cancer, ESCC and EAC, showed a similar overall survival between patients who underwent surgery, 64.1%, and patients who underwent endoscopic therapy including EMR with or without ablation, 55.5%. 265 High rates of performance of EMR also appears to be a significant predictor for a high eradication rates of B. 266,267 Complications of EMR include bleeding, up to 10%, perforation, 3%, and stricture. 257,268 Post-EMR strictures are, for the most part, responsive to endoscopic balloon dilation and are related to the circumference and length of mucosal resection. 269 In light of the encouraging reports with EMR in early esophageal cancer, patient selection is crucial. Major limiting factors of EMR are lymph node involvement, presence of lymphovascular invasion, and multifocal disease. 270,271 Ultimately, the best disease-free results with EMR have been reported with non-ulcerated or nodular mucosal lesions smaller than 20 mm in diameter, especially lesions that are well or moderately differentiated, intramucosal, and with no lymphovascular invasion. 272,273 Early enthusiasm for endoscopic treatment led to new techniques for lesions extending into the submucosa. ESD can potentially increase the size of the en-bloc local resection and remove submucosal tumors, Figs 48.15 and 48.16. 274 However, these lesions have a significant risk of lymph node involvement, and thus ESD in this setting would be only diagnostic and not curative. Most of the ESD experience comes from Japan, where en-bloc resection rates in ESCC of 100% and curative resection rates of 80% have been reported. 275,276 When comparing ESD to EMR in esophageal mucosal cancers 20 mm or less, ESD has been found to provide an en-bloc resection rate of 100%, whereas for EMR it was for 87%, cap-assisted, and 71%, two-channel technique. The curative resection rate for ESD was 97%, significantly higher than either EMR technique, 71% for cap and 46% for two-channel. Complications of ESD include perforation in 2% to 5% and stricture in 5% to 17%. 275-277 The European Society of Gastrointestinal Endoscopy recommends that ESD is the preferred method of endoscopic resection of ESCC given higher en-bloc resection rate and superior MSM-MPAAB visible lesion cap snare cap EMR band ligation EMR MSM-MP a visible lesion band snare Fig 48.13 Techniques for endoscopic mucosal resection. A. Cap-assisted endoscopic mucosal resection, EMR. B. Band ligation EMR. A. Adventitia, M. Mucosa, MP, muscularis propria, SM, submucosa. 714 Part V Esophagus Histological Assessment. EMR can be used for lesions 10 mm if en-bloc resection can be assured. For early EAC and HGD, EMR is still the mainstay method of endoscopic resection, but ESD can be considered for lesions greater than 15 mm, poor lifting tumors, and lesions with high-risk features for submucosal invasion. 278 Ablation can be achieved with radiofrequency ablation, RFA, or cryotherapy. Each method can be used alone or, more often, following EMR or ESD of visible nodules. Photodynamic therapy is rarely used in clinical practice currently due to high risk of adverse reactions, strictures and photosensitivity, and the availability of other ablative techniques. 279 RFA is being increasingly used in patients with beer-related HGD and low-grade dysplasia, LGD, and mucosal EAC after EMR is performed for any visible lesion, see Chapter 47, and in adenocarcinoma in situ. In contrast to photodynamic therapy, RFA is associated with fewer complications and better preservation of esophageal function. 280-282 Based on data from randomized controlled trials and large observational studies, RFA is the most widely used technique in the management of B-related neoplasia patients. RFA is not used as commonly in early ESCC, but a few recent reports demonstrated efficacy and safety of RFA for the treatment of early squamous cell neoplasia. 283 Although there is less evidence, cryotherapy also seems to be effective in early esophageal cancers. 284 A major limitation of ablation therapy is that it does not provide tissue for further pathologic evaluation and staging. Endoscopic therapy with palliative intent endoscopic dilation can be performed for treatment of dysphagia. However, the effect is typically short-lived and there is an increased risk of perforation. 285 Endoscopic placement of self-expandable metal stent can also be considered with excellent efficacy to alleviate dysphagia. The stents currently used are mostly covered stents due to better efficacy and less reintervention rate, Fig 48.17, 286 small diameter, 18 mm, and large diameter, 23 mm. Stents seems to have the same efficacy. 287 Stents can also be used in combination with other modalities, chemotherapy, radiotherapy, or brachytherapy, to alleviate dysphagia. 288 Endoscopic placement of gastrostomy or jejunostomy feeding tubes can help alleviate dysphagia and weight loss. Placement of gastrostomy tubes is not recommended in surgical candidates given that it may interfere with using the stomach as conduit. Moreover, using the pull technique for gastrostomy tube placement, metastatic seeding of the tube insertion site was reported. Direct gastrostomy tube placement may be favored to avoid this risk. 289 Covered self-expandable metal stent can successfully seal a trachea-esophageal fistula in up to 86% of patients with esophageal cancer. 290 Caution must be exercised when placing stents in ABCD Fig 48.14a to d. Examples of visible lesions detected at high-resolution endoscopy in patients with Barrett esophagus, arrows. Chapter 48 Esophageal Tumors 715 48 The middle third of the esophagus because of the possible extrinsic compression of the airway, which lies just anteriorly. 291 The ASGE recommends placement of esophageal stents for fistulas because they provide durable and immediate relief. 292 Chemotherapy and radiation therapy Neoadjuvant chemotherapy patients who receive preoperative chemotherapy and then undergo surgery and have no residual cancer have a better survival than those with residual or persistent cancer. 293-296 Results from North America and Europe have shown significant 3-year and 5-year survival advantages of preoperative and perioperative chemotherapy compared to surgery alone. 297-299 These results were seen in both ESCC and EAC. A large meta-analysis also showed that neoadjuvant chemotherapy was associated with improved survival and higher rates of complete R0 resection. 300 Although neoadjuvant chemoradiotherapy is the most common approach for locally advanced esophageal carcinoma, perioperative chemotherapy can be used as a treatment option for adenocarcinomas of the distal esophagus and gastroesophageal junction, GEJ. 301 Neoadjuvant chemoradiotherapy Neoadjuvant chemoradiotherapy has become the standard of Care for locally advanced esophageal cancer in many countries based on data from prospective trials and meta-analyses. 302,303 The Cross Study, Chemoradiotherapy for Esophageal Cancer followed by Surgery Study, which included patients with esophageal cancer, 75% with EAC and 23% with ESCC, randomized patients to neoadjuvant chemoradiation followed by surgery versus surgery alone. This study found that the combined modality arm had a longer median survival, 49.4 versus 24.0 months. Patients in the chemoradiation arm received perioperative weekly carboplatin, paclitaxel, and 41.4 GY of radiotherapy followed by surgery. A lower proportion of patients had a local recurrence in the perioperative therapy group compared to the surgery alone group, 14% versus 34%. Histologic tumor type did not affect survival. Both EAC and ESCC benefited from neoadjuvant chemoradiation therapy. 103,304 Neoadjuvant radiation therapy in contrast to neoadjuvant chemotherapy and chemoradiotherapy just discussed, studies have not shown any benefit for preoperative radiation alone. 305 The NCCN recommends that radiation therapy alone should be used only for palliative purposes or for patients who are not candidates for chemotherapy. 204 Newer radiation therapy techniques are aimed at increasing dose delivery to the target tissue while reducing toxicity to the surrounding organs, heart, lungs, skin. These techniques, such as intensity-modulated radiation therapy and proton beam therapy, are still being evaluated for efficacy in esophageal cancer patients. 306,307 Adjuvant chemoradiotherapy compared to neoadjuvant chemoradiotherapy. Adjuvant chemoradiotherapy does not appear to be effective, and a recent network meta-analysis showed no survival benefit when compared to surgery alone. 303 A retrospective study showed that adjuvant chemotherapy after neoadjuvant chemoradiotherapy and surgery was not effective in patients with no residual disease or with residual non-nodal disease, but was associated with improved survival in patients with residual nodal disease. 308 Targeted therapy patients with EAC should be tested for human epidermal growth factor receptor 2, HER2, on tumor biopsies. If high levels of expression are seen, HER2 antibodies such as trastuzumab and pertuzumab can be added to the chemotherapy regimen in patients with metastatic adenocarcinoma or locally advanced carcinoma where local therapy is not indicated. 309 In a recent trial, VEGF receptor 2 antibodies ramucirumab showed promising results for patients with advanced GEJ adenocarcinomas refractory to standard chemotherapy regimen and was approved by the FDA for this indication. 310 Pathology assessment. Marking of margin submucosal injection circumferential cut dissection of submucosa resection. Fig 48.15 Schematic description of the technique of endoscopic submucosal dissection. Redrawn from Current Gastroenterology Reports 2014, 16.5. 716 Part V Esophagus immunotherapy. Another recently FDA-approved therapy is pembrolizumab, an antibody to programmed death ligand 1, PDL1. Pembrolizumab is approved for refractory adenocarcinomas that are PDL1 positive or for tumors with microsatellite instability or that have DNA mismatch repair gene defects. 311 Prognosis. The best predictors of esophageal cancer survival are depth of invasion, T stage, and lymph node involvement, N stage. 312,313 A retrospective study found that the end stage of esophageal cancer was an independent factor affecting overall and disease-free survival, N1 disease-free survival of 13.6%, 314. The 5-year survival at presentation for local, regional, and distant disease was 41%, 23% and 5%, respectively. 315 The 5-year survival improved to above 90% when high-grade dysplasia, cancer in situ, or T1A cancer was diagnosed. 264 For those with loco-regionally advanced disease at presentation, 50% of patients, however, their outcomes are poor, and most have a recurrence and die within 3 to 5 years of their diagnosis. 315 In addition to the depth of invasion and number of lymph nodes involved, histologic type, degree of differentiation, and location of the tumor also have an impact. ABCD. Fig 48.16a, distal esophageal nodule at the 1 to 3 o'clock position with biopsies consistent with adenocarcinoma, b. Narrow band imaging of the same area with irregular pit and vascular pattern, c. Mucosal defect after endoscopic submucosal dissection, ESD, of the nodular area. D. ESD specimen pinned on a cork board. Fig 48.17 fully covered esophageal metal stent. Chapter 48 Esophageal Tumors 717-48 on the survival. 247 Despite the recent advances in treatment, the most recently reported overall 5-year survival rate is only 19%. 3 Recent interest in brain metastases from esophageal cancer has been reported. Metastatic brain lesions are rare in esophageal carcinoma, with a recent report showing incidence of 3.8%. 316 Most of the reported cases are associated with EAC rather than ESCC. 316, 317 Other malignant epithelial tumors. Squamous cell carcinoma variants. Verrucous carcinoma is a rare variant of ESCC, with less than 30 reported cases. 318 It is most commonly found in middle-aged individuals, and 2/3 of affected patients are men. Endoscopically, it presents with a papillary or warty appearance. The diagnosis requires a high index of suspicion and multiple biopsies because histology reveals well-differentiated hyperkeratosis and acanthosis with only a small column of neoplastic cells. 318 Despite the fact that these lesions are typically well-differentiated and slow-growing, they generally have a poor prognosis given the delay in diagnosis. Another variant of ESCC is carcinosarcoma, also known as pseudosarcoma, spindle cell carcinoma, and polypoid carcinoma. This tumor presents with a polypoid appearance and can be solitary or multiple. Owing to the exophytic nature of the tumor, many patients will present with dysphagia or epigastric discomfort. Histologically, the tumors have a spindle cell component. They tend to have invaded the esophageal wall and spread to regional lymph nodes at the time of diagnosis and can metastasize. Therefore, these tumors are associated with a poor prognosis, 2-year survival of 25%. 319 Small cell carcinoma. Small cell carcinoma of the esophagus is a rare entity, accounting for 0.8% to 3.1% of all esophageal malignancies. The tumor is highly aggressive, with a very poor prognosis. The average age at diagnosis is 65 years, and 2/3 of affected patients are men. Dysphagia, weight loss, and epigastric pain are the presenting symptoms. There is usually a history of tobacco use, 90%, and alcohol use, 70%. The tumor is typically located in the middle third, 52%, or lower third of the esophagus, 35%. More than half of affected patients have extensive disease at the time of diagnosis. 320 The optimal management of these patients is not well established, but chemotherapy should always be a part of the multimodality treatment. 321 For a very select group of patients with limited disease, resection followed by chemotherapy may provide long survival. 321 The median overall survival is only 11 months, with a 2-year survival of just 25%. 320 Malignant melanoma. Primary esophageal melanoma is rare, with just over 300 cases described. 322, 323 Melanoma accounts for 0.1% to 0.5% of all esophageal malignancies. 324 Primary esophageal melanoma metastasizes early and has a very poor prognosis. Melanocytosis at the basal layer of the epithelium caused by basal hyperplasia or chronic esophagitis is thought to play an important role in its pathogenesis. 325, 326 Melanoma affects men twice as often as women. The average age of presentation is close to 60 years. 324 Dysphagia is the most common symptom. However, because of the soft nature of the tumor, symptoms can be delayed, and the size of the tumor at presentation is larger than 2 cm in over 90% of cases. The most common locations are the middle and distal thirds of the esophagus. 323 Endoscopic characteristics include a non-ulcerated, pigmented tumor, although the color may vary depending on the amount of melanin, and an amyloidic variant has been described. 327 Satellite lesions occurring a few centimeters from the primary, larger lesion can be seen and are thought to be due to intramural metastasis. Histologically, melanoma can be misdiagnosed as poorly differentiated carcinoma owing to the lack of melanin granules, and immunohistochemistry may be necessary for establishing the correct diagnosis. 324 This is an aggressive disease and the incidence of regional lymph node and distant metastasis at presentation is high, 40% to 80%. 328 FDG PET is currently the most accepted modality for detecting metastases. It is important to distinguish primary from metastatic melanoma, because metastatic melanoma, discussed later, can involve the esophagus in 4% of cases. 329 Radical resection combined with lymphadenectomy is the main treatment approach. The calculated 5-year survival rate for primary esophageal melanoma is 37%. 330 stage, tumor location, and lymph node involvement are independent predictive factors of prognosis. 331 Benign epithelial tumors. Squamous papilloma. Esophageal papillomas are asymptomatic. Benign epithelial tumors characterized endoscopically by a solitary, exophytic lesion in the lower third of the esophagus, Fig 48.18. They tend to have a white or pink color. They have a soft consistency and a smooth or slightly rough surface. Histologically, they reveal finger-like projections of connective tissue lined by an increased number of squamous cells. The endoscopic differential diagnosis includes glycogenic acanthosis, verrucous border of squamous cell carcinoma, and verrucous carcinoma. 332 Squamous papillomas are rare, with a reported prevalence ranging from 0.01% to 0.43%. 332 Their pathogenesis is uncertain, but it has been hypothesized to be related to underlying inflammation, e.g., from GERD. 332 Another theory of pathogenesis is infection with HPV. 333 Papillomas are generally amenable to endoscopic resection, mostly using forceps. Given their small size or mucosectomy techniques, recurrence after resection is uncommon. Malignant transformation has been reported in a few cases with multiple papillomas, esophageal papillomatosis, but cancer is rare in isolated lesions. 334,335 Focal dermal hypoplasia, Goltz syndrome, a rare condition usually affecting females, is characterized by multiple abnormalities of ectodermal and mesodermal structures. Although dermatologic, ocular, and musculoskeletal manifestations dominate the clinical picture, esophageal papillomatoses may be present. 336,337 Caused by a mutation in Porctin on the X chromosome, Goltz Fig 48.18 Esophageal papilloma seen at esophagoscopy. 718 Part V Esophagus syndrome has a dominant X-linked inheritance that is usually lethal in affected males. Goltz syndrome can be inherited or occur de novo. Adenomas of the esophagus are rare and almost exclusively associated with Barrett metaplasia. Although adenocarcinoma is a much more frequently recognized lesion associated with Barrett, several cases of adenomas have also been reported. 338-340 They characteristically present as polypoid lesions within a segment of Barrett in the lower third of the esophagus. Histopathology shows dysplastic tubular glands covered by specialized intestinal epithelium. Similar to colonic adenomas, these are considered to be premalignant, and endoscopic resection is recommended for diagnosis and treatment. Inflammatory fibroid polyp. Inflammatory fibroid polyp, also known as inflammatory pseudopolyp or eosinophilic granuloma, is characterized by a distinct histology. This includes a submucosal-based polypoid lesion with perivascular, concentric fibroblastic proliferation with an increase in eosinophils. Most polyps express CD34 and are negative for CD117. They most often are found incidentally in the stomach and large intestines, followed by the small intestine. The esophagus is a much less likely location, 2% of cases. 341 They are non-neoplastic polyps and follow a benign course. Malignant non-epithelial tumors. Lymphoma of the esophagus can be primary or secondary, with primary lymphoma being far less common. Primary esophageal lymphoma is defined as a lymphoma having predominantly esophageal involvement with only regional lymph nodes affected in the absence of disease in peripheral or mediastinal lymph nodes, spleen, or liver, and with a normal chest radiograph and WBC count. 342 Lymphoma accounts for less than 1% of esophageal malignancies. 343 Clinically, Esophageal lymphoma can present with dysphagia, weight loss, GI bleeding, esophageal fistulas, and other nonspecific systemic symptoms, e.g., fevers, night sweats, fatigue. Endoscopically, the few cases that are reported describe a range of findings including submucosal nodules, masses, ulcerations, and polypoid lesions. Esophageal lymphomas can be either the Hodgkin type or non-Hodgkin lymphoma, NHL. Diffuse large B-cell lymphoma, DLBCL, is the most common subtype of NHL and has been associated with immunosuppressive states such as AIDS. See Chapter 32. 344 Sarcomas of the esophagus are rare mesenchymal tumors that include leiomyosarcomas, gastrointestinal stromal tumors, GISTs, see later in Chapter 33, rhabdomyosarcoma, fibrosarcoma, liposarcoma, fibrous histiocytoma, Kaposi's sarcoma, and choriocarcinoma. Leiomyosarcomas are the most common subtype and can be difficult to distinguish from benign leiomyomas. Tumors can be of intraluminal, polypoid, or infiltrative/invasive. Histologically, they consist of interlacing whorls of spindle cells with increased mitoses and marked pleomorphism. Mucosal biopsy is not a useful diagnostic tool in most cases, because these lesions are submucosal. On the other hand, EUS with FNA has been shown to be helpful for diagnosis. Lymph node involvement occurs in a third of cases. Esophagectomy with lymphadenectomy is the mainstay of treatment. Prognosis is poor and the 5-year overall survival is 35%. 345 GISTs are the most common mesenchymal tumor of the GI tract and are discussed in detail in Chapter 33. GISTs occur in the esophagus in only 1% to 3% of cases. 346,347 Typically they arise from the muscularis propria and more specifically, the interstitial cells of Cajal. They typically present after the age of 40 and symptoms can include dysphagia, bleeding from ulceration, dyspepsia, and weight loss. Endoscopically, they are most often encountered as submucosal solitary masses in the distal third of the esophagus. GISTs are seen on CT scan as well circumscribed, hypoattenuating masses. 348 EUS is the most accurate imaging modality, and can even help predict malignant potential. 349,350 On histology, GISTs mostly show characteristic spindle-shaped cells with elongated nuclei that express CD117 encoded by the KIT gene. CD117 and DOG1 positivity is an important differentiating characteristic because similar lesions, such as leiomyomas or other spindle cell tumors, are typically CD117 and DOG1 negative. As discussed in Chapter 33, the risk of malignant transformation of GISTs depends on the size of the GIST and its mitotic rate. Characteristics of GISTs with low malignant potential lesions include those smaller than 2 cm and a mitotic rate less than 5 per 50 high power field. 351 Treatment of GISTs depends on size of lesion and stage. Recent reports indicate that ESD could become a more frequently used technique to resect small, non-advanced lesions. 352 Otherwise, surgical resection is the traditionally preferred method of treatment. Tyrosine kinase inhibitors such as imatinib mesylate, Gleevec, are also an option as neoadjuvant therapy or for unresectable GISTs, see Chapter 33. CT and PET scans have been shown to be useful in monitoring patients after treatment. 353 Metastases to the esophagus are a rare occurrence. The two most common cancers to metastasize to the esophagus are melanoma and breast cancer. Typically, metastatic lesions cause extrinsic compression, with dysphagia a common symptom. EUS with FNA cytology can be helpful for diagnosis. Treatment most often consists of palliative endoscopic stenting. Benign non-epithelial tumors. Leiomyomas are the most common benign esophageal tumors. They affect men twice as frequently as women. 354 The lesion is seen endoscopically as a submucosal solitary mass or masses in the middle or distal third of the esophagus. Biopsy is usually non-diagnostic because leiomyomas have normal overlying mucosa. EUS is the diagnostic test of choice. A leiomyoma is seen typically arising from the muscularis propria. Only large, greater than 5 cm, Symptomatic lesions require excision, which can be done endoscopically for smaller tumors, using ESD techniques, or surgically. 355 Granular cell tumor. Granular cell tumors are most commonly located in the head and neck region, including in the oropharynx, and are less common in the GI tract. The most common site of GI involvement is the esophagus, accounting for 33% of cases. The endoscopic appearance, location within the esophagus, and number of lesions is variable. 356,357 Typically, granular cell tumors are solitary, submucosal lesions with a yellowish appearance, typically in the distal esophagus. They are mostly found incidentally on upper endoscopy, because most patients are asymptomatic. Histologically, granular cell tumors are composed of round or polygonal cells. Chapter 48 Esophageal tumors 719-48 with abundant eosinophilic cytoplasm. The cells are periodic acid Schiff positive and diastase resistant. They may have a neural crest origin, as evidenced by immunohistochemical expression of S100 protein. Although a few cases of malignant transformation are reported, the majority of cases are benign. 358 Endoscopic resection is recommended, has been shown to be safe, and allows for a more accurate histologic diagnosis when required. 356 Fibrovascular polyp. Fibrovascular polyps are benign esophageal lesions, Fig. 48.19. They are almost exclusively seen in the cervical esophagus, likely because of the relatively loose submucosal tissue and redundant mucosa in this anatomic region. 359,360 They are typically pedunculated polyps consisting of blood vessels, adipose cells, and stroma covered by normal squamous epithelium. Although most cases are diagnosed incidentally, large polyps have been described to cause dysphagia and globus sensation. Peculiarly, prolapse of fibrovascular polyps out of the mouth has been described as fleshy tissue seen after vomiting or retching. Rarely, these polyps can cause fatal asphyxiation, and thus endoscopic or surgical removal is recommended. Some recommend EUS of larger polyps to determine the presence of large blood vessels prior to excision. Hamartomas are rare lesions in the esophagus. They are typically pedunculated polyps that can cause symptoms similar to fibrovascular polyps, i.e., dysphagia, globus sensation, polyp prolapse, asphyxiation. Endoscopically, the two entities are indistinguishable. However, hamartoma II polyps are much less common and have a different histologic appearance. They often contain multiple tissue types, including cartilage, bone, adipose tissue, smooth muscle, and skeletal muscle. Endoscopic or surgical resection is recommended. 361 Hemangioma. Hemangiomas of the esophagus are rare vascular malformations that can occasionally present with GI bleeding or dysphagia. There are two histologic types of esophageal hemangiomas, cavernous and capillary. Most lesions are of the cavernous type. Endoscopically, they are seen as blue to red-colored submucosal nodules, which often will blanch with compression. 362 Interestingly, biopsy has not been associated with hemorrhage in reports. 363 Previously, surgical resection was the most common method of treatment, although endoscopic treatment is possible. 364 Lipomas are rare benign tumors of the GI tract. Lipomas are more commonly found in the colon, small intestine, and stomach than in the esophagus. Almost all are asymptomatic and found incidentally on endoscopy as slightly yellowish, raised nodules in the proximal esophagus. Large, pedunculated esophageal lesions can cause dysphagia and asphyxiation. Often, esophageal lipomas exhibit the pillow sign indentation or cushioning with palpation. Superficial mucosal biopsies will usually be non-diagnostic. Deeper samples from the submucosa will reveal well-differentiated adipocytes. On EUS, a homogeneous, hyperechoic submucosal lesion with smooth outer margins is seen. Treatment of symptomatic lipomas is endoscopic or surgical resection. 365 Conflicts of interest and acknowledgement. SW, supported by the University of Colorado Department of Medicine Outstanding Early Scholars Program, Consultant Medtronic, Boston Scientific. HH, Consultant Medtronic. Neil C. Patel and Francisco C. Ramirez contributed to earlier versions of this chapter.